Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. Thanks for your company. This evening our programme focuses on growth. In particular, we'll discuss the varied health and physical development problems associated with under or overnutrition. We'll also hear from clinical geneticist Dr. Gareth Bainham about some red flags that could be indicators of underlying genetic causes for abnormal growth. And we'll talk to Dr. Hannah Seymour, Chair of the Falls Prevention Health Network, and Suzanne Ralston from the Injury Control Council of WA about falls prevention and the Stay on Your Feet programme. So let me introduce our panel for this evening's programme. Dr. Peter Maguire joins us to chair our discussion tonight. Welcome back, Peter. It's been a while.
It has, Jerry. It's good to be back. Thanks.
And joining Peter, our paediatrician, gastroenterologist, Associate Professor David Forbes from Princess Margaret Hospital. Welcome, David.
Thanks, Jerry.
And joining him is pediatric endocrinologist Dr. Tim Jones, also from Princess Margaret Hospital. Welcome along, Tim.
Thank you.
Now, before we begin, a reminder to you that this is an interactive program, so if you have any questions for Peter, Tim or David, you can have your say at any time by giving us a call on 1-800-673-277 or 089-229-5241. So, Peter, growth. Let's grow.
Let's take it away. Thanks, Jerry. And David, I might start with you, perhaps. There's been a lot of concern in the media and public discussion about childhood obesity. Can you tell us a bit about how big a problem it really is and any idea why it's becoming that way?
Okay. Well, certainly it's a hotly debated point if people have been following the media recently, but we'll show you a graph of the increase in Australia and a number of other countries of late, which shows a steady increase from the 1970s. You can see there in that graph, Australia in the red, and there's been steady progression upwards across all of those countries. If we look at the next graph, the headlines, we'll just see some of the controversy about this. This was in one of our national papers earlier this year and suggested that it was a big beat up and it wasn't really a problem. But if we can just flick to the next graph, you can see the main point of this study was that there is an increase in all parts of the community, but this is much more a disease of those who are less well off, the low socioeconomic groups. Why? It's probably different in every community. If you look at studies around the world, it doesn't track with socioeconomic status quite the same way as it does in Australia. In some countries of the world, wealth is a risk factor for boys, but not for girls. But the things we know here are related to sedentary lifestyle, the number of screens, and changing patterns of eating, the principal factors.
Okay, thanks. Well, it might be useful to talk about a case and bring it sort of closer to the coalface. And if we take Tyrone, who's a 10-year-old boy, and he attends a general practice with his mum, who's both of them really are significantly overweight. And mum says to the doctor that she wants Tyrone checked out in case his weight problems are due to his glands, which I'm sure we all identify with. Tim, how often is it due to his glands?
It's rarely due to glands, but that's a question that everyone's looking for the cause of weight gain and obesity in their children, and they want to rule out that it comes from the glands first, or from other sources.
So taking that sort of scenario, what aspects of the history would you be interested in looking into?
Basically in the history, you're looking for the possible causes of obesity and also the consequences of it or the complications of it. So when you're looking at causes, you'd want to see how quickly the obesity started, when it started, the natural history of what happened to this child, the family history of obesity, type 2 diabetes, metabolic syndrome, the picture of the whole family. If you've got one child, for example, who's obese, with 3 siblings who are skinny, you might be looking at a different causation than simple obesity. And then you're looking for the glandular things. You're looking for other symptoms and signs of hypothyroidism or excess cortisol. The very rare causes of obesity, which we do see from time to time. It's growth is a very important question. If the child stops growing and is obese, then it's likely to be glandular. If the child's tall and obese or is growing fast, then it's likely to be simple obesity.
So it sounds like it's very important to try to get hold of the growth charts to see
Yes.
what's been happening over time.
That's the key. Yeah. If you've been monitoring growth, or if they've got a chart at home, that will help you a lot.
And what about the physical examination? What sort of pointers to some of those conditions you were talking about?
Well, again, the height. A short, fat child is likely to be something other than simple obesity. Simple signs of hypothyroidism, excess cortisol are important to look for. And there's a skin condition called acanthosis nigricans it's important to look for, because that will be a marker of insulin resistance or simple obesity. And
David, might give you a turn here and just talk about the sort of test, because I guess most of us would look at the child and think, well, this looks like, not one of the rare ones, but one of the stock standard sort of obesity things. But I guess we feel that we should do some tests. And what should we do? Or what's overdoing?
Well, if you're ruling out glandular problems, you're going to look at thyroid function and morning cortisols to start with. They're simple, most labs will do them, but Tim probably is more appropriate to talk about the specific tests looking for consequences of obesity, because it's really his special area.
Yeah, the comorbidities, they include hyperlipidemia. Well, the first on examination looking for hypertension.
Okay. Yes.
Joint problems, back problems, sleep disorder, and then on testing looking for hyperlipidemia, evidence of insulin resistance. Fasting insulin is important. If there's a strong history of type 2 diabetes, you want to measure fasting glucose, and sometimes an oral glucose tolerance test. We've seen an explosion in the number of oral glucose tolerance tests ordered on children in the last 10 years.
It's not something I would have thought about in general practice much. So so how many of those largish kids who are sort of, significantly overweight but not out of the ordinary in the community, how many of those should we be doing those sort of tests on?
Well, that's a good question. I think you've got to look at their BMI. If they've got a BMI that's in the extreme range. If there's a very strong family history of type 2 diabetes in one parent or both parents. If they're indigenous, or if there's acanthosis nigricans, then you're going to be looking closely at their glucose metabolism. Having said that, of all the children that are obese in West Australia, there's only 50 with type 2 diabetes that we know of, but it is increasing. It needs to be looked for.
So we won't see it every day, but it's important to look for it.
Yeah.
Tell me a bit more about the lipids. I've seen some recent suggestions that we should be screening high-risk children for their lipids, and I don't think I've ever really ordered a fasting lipids in a child, so
I think
when should we start doing it?
If there's a family history of hyperlipidemia, you should do it. If there's a family history of early cardiovascular disease, some people recommend you should do it. And we do in all obese kids, because we do see elevated or dyslipidemia in that group.
Same sort of normal ranges, or?
There are published ranges for the paediatric population. Yeah.
Do you mind if I just ask Tim a question? What about hemoglobin A1Cs in fat kids in the community? Are they worthwhile?
We found it useful in indigenous groups where there's a very high rates of indigenous children where there's very high rates of type 2 diabetes. They're not as good as a screening tool as a straight glucose.
Okay. And I suppose the question that GPs always ask is, when should we be thinking about referring these kids for, more specialised care, particularly from rural areas where it's a big deal to send someone in?
I think in those in whom you think have impaired glucose tolerance, if you've done the investigation, you've found an impairment of glucose tolerance in the extremely obese children, in the children with sleep disorder, sleep apnea, those with complications and comorbidities, the top end.
Right.
The majority need to be looked after in general practice.
The other group I think you haven't mentioned are those with abnormal liver biochemistry too.
Yes.
Because you do see non-alcoholic steatohepatitis and hepatitis in kids.
So liver function tests added to
thanks for
the
reminding me.
regime.
I think anyone with persistent obesity, particularly if they're in the obese rather than in the overweight range.
Great. I'd like, and perhaps David, you're perhaps a good one to talk about this. There's a culture of blame around this with parents sometimes, and I think parents feel guilty, and sometimes perhaps we contribute to that, perhaps by almost blaming the parents for the kids' obesity. And I've seen some suggestions that maybe they should be charged with neglect. And I saw a thing in the paper the other day about report cards for fat kids. And is that sort of thing helpful, do you think, David, or are we really just creating a problem?
I was a bit alarmed to see a proposal that fat kids are going to be made to run around the oval every morning.
Yeah.
You know, it might do them some good. It might punish them. That paper I referred to earlier that was highlighted in the Australian. One of the interesting findings from that was that perceptions of obesity vary very much across our community, and so that there are some ethnic groups who don't view overweight and obesity in the same light as the rest of us. So Indigenous people, Pacific Islanders, many Middle Eastern people regard a healthy covering of body fat as desirable and makes the children more attractive. So I think we do have to put it into the cultural context. At the same time, we shouldn't ignore the risks. So I think this is something that you have to take very carefully, but I don't think a culture of blame is going to help anyone. Most people get defensive around food, and so it's really trying to educate families, get them to change their approach to eating and activity, and work with them in that environment. But this is a whole of society problem. It's not a problem that's isolated to a couple of families here.
Nonetheless, though, the GP is in a very good position to be able to provide this sort of education and the education support to parents. Would you agree?
Oh, absolutely. And I think they have a responsibility to point out risks. And they can point out the simple things that might be useful. But the reality is there is no really standout intervention that's going to make a big difference. There is evidence that it is a problem that might have its genesis in the womb, or maybe even in your grandparents' womb. So there's some recent evidence of genetic priming, which is passed through several generations. So it's a very complex problem. And I don't think targeting fat kids and their parents is all that helpful.
Okay. But that does lead us to talking about those management issues and what the GP can do when faced with Tyrone and his mum in the consulting room. And what sort of approach do you think is useful?
Okay, well again, Tim's got some specific experience at the high-end group of a program that's been successful.
At Precious Smoke Hospital, we'll only see the severe ones that have got impaired glucose tolerance, and we use a multidisciplinary team approach with exercise physiologist, dietitian, social worker, psychologist, nurse to really attempt to address all aspects of that family's life, and we'll only treat a child when the family comes along. So the parents have to be involved as well. So it's basically you've got to treat the whole family. You show them what the problem is, show them what the consequences are, and then try and give them tools to deal with that and change their lifestyle. But that's as we all know, that's not easy to achieve.
No.
So if you translate that into general practice, it's the same sort of approach built around the relationship of a primary practitioner. He has with the family, he's trusted, he understands their needs and can work at those things over time. But it's like lots of things that are associated with behaviour. We can't fix them with a prescription. We need regular reinforcement. Sometimes the risk of being accused of over-servicing. But I think in terms of behavioural change, we don't really have any other tools except regular reinforcement of simple messages.
Sounds like an argument for continuity of care, which is a bit of a debate at the moment. But it does sound like it's a long haul
It is. I think
process, and I guess that must be difficult. How long do you maintain those contacts
well, we
with
do
those
an
families?
intense 10-week course, but we will maintain the contact till they show an improvement, or they don't.
Which
but
I suppose is our advantage, that we can probably do that. If we really take it on, I guess we can do it over months and even years if we.
I think it's that relationship with the family or the parent and the child that's critical. As long as it's one person doing it, it doesn't matter if it's a dietitian or a GP or.
And I think that puts it in the context of a behavioural problem rather than just an eating problem or an activity problem. If you look at the evidence about interventions, many interventions will cause some improvement in physical fitness or some decrease in food intake, but very few of them, measured in the relatively short term, have a significant impact upon body mass index. So I think you have to take it away from just those things and look at it as a behavioural, psychosocial problem which you try and change over time.
Just on that point of psychosocial, what sort of impact, doesn't one have to be very careful about what sort of psychological impact you have on a kid? You say to a kid, you're fat, this is the reason, this is what you need to do about it. Is that a delicate balance between trying to get them to modify their behaviour and leaving some sort of impression on them that may be negative?
Absolutely, Jerry. And if the primary practitioner knows the family, knows the child's vulnerabilities, that's much more important. Part of my practice is in undernutrition in adolescence, and we see lots of young people whose anorexia is triggered by the weigh-in in the science class and the rating, so that they're at top of the tree, and they're shamed. So I think that can have a very, very deleterious effect on young people.
Controversial area, I guess, is drug treatment or even more drastic treatments. What is the place, if any, for drug treatment of overweight kids? Perhaps
There's very little evidence that drug treatment in adolescents works.
At all? Okay.
Yeah.
There's some limited evidence for sibutramine in adolescents, but I'm only aware of one good study from the US, and the magnitude of the effect, it's sort of less than 10% drop. And
okay, so that's not a lot.
Not a lot.
At the top end of the scale.
Which is more than some drugs that are promoted too.
What about those kids who've got that genetic predisposition to obesity or overweight? Is there a different modality of treatment there?
Not yet. Not yet. 5% of severely obese kids have got a known genetic mutation, but that doesn't allow. That's not translated into any specific treatment yet. That's the idea, but we're not there yet. We do use metformin sometimes in obese kids that are insulin resistant, and you can get some short-term improvement with that, but it's not dramatic, and it's hard to get them off it once they start.
Yeah. I wonder if what you're referring to when you're saying genetic is that the multi-generational obesity, and is that really genetic, or is that a reflection of poverty and socioeconomic status as much as it is genetics, learned behaviour?
So that would involve a detailed investigation of the family history going back generations?
Involve a detailed history and assessment of behaviour and lifestyle. And I think for most families it's probably going to be the most important aspect.
Yeah, so it sounds like it's, to sort of summarise that a bit, it sounds like there's no easy answers here, that really history examination are important, and there are some conditions but that are important to look for, but basically in most cases we're talking about behaviour change in a family over longish periods of time.
And that, I think, raises the issue of the next point of intervention that we're going to see over the next decade. That's early intervention. So prolonging breastfeeding, care about introduction of solids, preventing the early adiposity rebound. Most children lose weight in the first year or move down on their centiles during the first year of life, and if they catch up really quickly, then they're more likely to have long-term obesity.
Can't resist the question. what about solid introduction? Parents do ask, what age should I introduce solid?
Okay, the National Health and Medical Research Council says that you should delay introduction of solids after 6 months. There's concern being expressed that that's too late, primarily because it might be a risk factor for development of allergy because of failure of development of tolerance in the first 6 months of life. And it's been raised as a possible contribution to the epidemic of allergic disease we're seeing at present.
Interesting.
We might take a break there, Peter. If you'd like to ask Tim or David a question, or Peter, give us a call, 1-800-673-277 or 089 229 5241. Dr. Gareth Bainham is a clinical geneticist from King Edward Memorial Hospital and is also involved with the Telethon Institute for Child Health Research. He recently spoke to us about some key indicators to look out for when considering the possibility of a genetic growth disorder.
Individually, genetic conditions are uncommon, but in totality, they are relatively common single gene genetic disorders that would affect at least 1% of the general population, and more complex multi-gene disorders would affect up to 10% of the general population. Certainly, GPs are well aware of many common genetic conditions such as cystic fibrosis, hemochromatosis, inherited familial cancers, common chromosome problems like Down syndrome. And today I thought, rather than giving a didactic lecture per se and focusing on individual cases, although we'll touch upon a couple for illustrative purposes, I thought it'd be important to raise some red flags that might make GPs or other doctors think about the possibility of a genetic cause for abnormal growth. And really the red flags apply to overlap significantly between small stature and tall stature, under and overgrowth. And when people are thinking about abnormal growth, really they need to think about the company that it keeps. And in genetic terms, when I'm talking about that, I'm talking both within the individual and within that individual's family. So it's very important to ascertain a family history. A family history will often provide you with very useful information and will guide you and help refine your diagnosis and your thoughts. The second point is, when talking about the company it keeps, is to think about what else is associated within that individual with that condition. And when we're thinking about abnormal growth, the sort of things I'd be talking about is that individual dysmorphic? Do they have an unusual appearance? Do they have other problems? In particular, do they have other organ abnormalities? Is their growth disproportionate? Disproportionate growth might point to a skeletal dysplasia, or it might be part of a recognised syndromic cause of overgrowth. And when we're thinking about disproportion, I guess then we're thinking about abnormal body proportions. And with abnormal body proportions, that might be limited to one side or the other. It might be limited to one region of the body or the other. And that can give a clue to about a possible genetic cause. And sometimes can give clues to things like mosaicism, where there's a mixture of genetic constitutions within an individual. So they're all important pointers. I guess mechanistically, when you're thinking about causes, certainly when you think about genetic causes, you're thinking about an imbalance between growth promoting and growth suppressing factors. And there are two conditions which illustrate that concept quite well. They're conditions called Russell-Silver syndrome and Beckwith-Wiedemann syndrome. And I'm sure general practitioners would have at least heard of those conditions previously. The reason that they're interesting from a mechanistic point of view is more recently it's shown that in fact it's the same genetic region, it's the same region of part of chromosome 11 that, at least in a proportion of both those cases, is abnormal, and abnormal in a reciprocal kind of way, almost opposite genetic mechanisms within the same region causing divergent disorders. So a typical child with Russell-Silver syndrome, and I think there's some slides of a case of a little boy who was about 16 months of age who was referred with short stature, and in combination with his short stature he had some of the pointers we talked about. So he had disproportion both in terms of his head circumference relative to his stature. He also had disproportion in terms of hemihypertrophy, having a smaller side one compared with the other, and in fact had a further disproportion, having an abnormal arm span for his height. And then some other features that you might see in that condition, with a triangular sort of face and a prominent forehead, declinodactyly of the fifth finger and some cafe au lait lesions. So he was a relatively classic case of that condition. It was a clinical diagnosis that was relatively easy to make, but often it's not. Often the features are nowhere near as atypical as that. They may overlap with other conditions. And while you might suspect that as initial diagnosis, you may think about other possibilities, and hence you embark upon the relevant investigations. There's the importance of, well, why bother even making the diagnosis in the first place? Well, one, it gives a person certainty. Once they know what their diagnosis is, that they're no longer looking for an answer. And it may mean that then you avoid a whole raft of unnecessary investigations. You can then also tailor the treatment to that specific condition if there are specific treatments for those, or you may be able to provide surveillance so that you look for things that are associated with that condition which you otherwise wouldn't look for. In this instance, there are a number of things that might be useful for this child. Developmental problems are more common in Russell-Silver syndrome. Certainly not every child with Russell-Silver syndrome will have developmental abnormalities, but they are more common. And so developmental assessment would be important. An assessment by the endocrinologist for the growth, whether the suitability or not for growth hormone replacement, and the importance of hypoglycemia in Russell-Silver syndrome, which is important when people are thinking about things like surgery, perhaps putting them first on the list, or if they get sick, think about the need to monitor their blood sugar levels. Provision of adequate and correct information may be one of the most useful things you do in that setting. Treating the associated abnormalities, and then for parents, they'll want to know what's the chance of it happening again, for instance, if they're planning further children. And usually Russell-Silver syndrome is a one-off, usually it's a sporadic event. So there's another condition called Beckwith-Wiedemann syndrome, which is a relatively well-known overgrowth condition. And a proportion of cases, perhaps 2/3, are due to abnormalities in the same chromosomal region as those with a number of cases of Russell-Silver syndrome. Basically, it's the reciprocal, it's the opposite sort of genetic mechanisms. This particular case, there was a child who was overgrown at birth, had hypoglycemia, and there was some asymmetry, so again, another useful pointer. So this child then went subsequently to have a number of things in terms of helping to manage that condition, but one of the important ones was tumour surveillance. So in this condition, there's an increased risk of tumours, predominantly intra-abdominal embryonal type tumours, so Wilms tumour and hepatoblastoma being the most common ones. And that tumour risk is age dependent, being highest in the first 4 to 8 years of life, and then tailoring off. And in this child, her underlying genetic mechanism put her at particular risk, and she in fact was in the highest risk group within this condition, having about a 25% chance of tumour. And she went onto a tumour surveillance regime, including some alpha-fetoprotein level measurements, which subsequently were raised, and she was found to have hepatoblastoma. The importance of that was early diagnosis, and the tumour could be treated by resection as opposed to other children where it may have been diagnosis may have been made late, and they may have, for instance, needed a liver transplant. So you can see again the usefulness of that diagnosis. We talked through the sort of list of red flags, and both these cases have a lot of them. In this case in particular, it was overgrown to start with, and I guess that overgrowth was disproportionate in terms of the family history. Both parents were really of normal to short stature. And then it was disproportionate in terms of the asymmetry, the asymmetry of the growth. The other flag here was hypoglycemia in the neonatal period. Now there are lots of causes for that, but in an overgrown child, that should certainly lead you to think about Beckwith-Wiedemann as one of those possibilities. So is there a family history of abnormal growth? Is the child dysmorphic? Does the child have learning difficulties or mental retardation? Are there other organ anomalies? And is there asymmetry or disproportion? Clearly there are going to be, the non-genetic causes are going to far outweigh the genetic causes, but they're an important component of the differential diagnosis.
Our thanks to Dr. Bainham for taking the time to talk to us. And if you're interested in more information about genetic disorders, Dr. Bainham recommended the Centre for Genetics Education website at www.genetics.com.au. And he also extended the invitation to any GPs looking for advice on genetic conditions to call him or his colleagues at the Genetic Services of Western Australia on 089340 1525. Those links and contact details will be available on the Rural Health West website. Before we return to our studio discussion, a reminder to call in at any time if you have any questions or comments for the discussion. The number is 1800 673 277 or 08 9229 5241, and that's precisely what Graham Rowlands from Norseman has done. Good evening, Graham.
Hello, is you there?
Yes, we are. Who's your question directed to, Peter? Graham?
Ah, there we are.
Yes, you're on.
Guys, I appreciate that you're not cardiologists, but I do have a youngster, a 6-year-old with a familial hypercholesterolemia syndrome, and grandfather is in fact at 60-odd had his first infarct. Father does have hyperlipidemia, and the little 6-year-old with a BMI in the high 20s has a total cholesterol in the 6, HDL's above 1, and LDL's quite significantly elevated. Kid's not yet on a statin. When do we start thinking about that, having already introduced regular exercise, good diet, and dietitian and family follow-up?
Tim, sounds like one for you.
We use statins definitely once children hit puberty. In the prepubertal children, we're a bit less clear as to whether we should be using them or not. But I think this child obviously needs some specialist referral and assessment and monitoring.
Thank you.
Yeah, in that context, who runs the? Do we just send them off to a PMH cardiology clinic?
Well, Tim's group sees some of these kids. The other group is the metabolic clinic at Princess Margaret Hospital. Andrew Martin is starting working with the familial hyperlipidemia group at Royal Perth Hospital, and they're starting a program later this year. So either Tim's endocrine group or Andrew Martin and Jeff Knight's metabolic group.
Does that help, Graham?
Wonderful, thanks very much.
Thank you, thanks for the call. Peter, before you move on, you want to return to that discussion on overweight?
Well, just before we move on to short or problems of underweight, there was one condition that we've got a couple of slides of, and I thought we'd put the slides up and let the audience see if they know what it is before asking you to comment. So it's pictures in front of you, and I hope everyone's had a punt at that. So, Tim, can you tell us a bit about this condition?
This is known as acanthosis nigricans, which is a thickening of the epidermis, usually in the creases, and especially the neck or in the axilla, and it reflects insulin resistance. And so if we see acanthosis nigricans, we know we're going to have very high insulin levels, and it actually implies a high risk for type 2 diabetes and impaired glucose tolerance. So if we see that degree of severity, we'll investigate.
Is it prevalent among certain groups?
It's more prevalent if you look amongst indigenous groups, but any group that shows severe obesity with genetic predisposition to insulin resistance, you'll see it.
And not surprisingly, it's a well-documented risk factor for liver disease in association with obesity.
Yeah.
So worth looking out for?
It's definitely worth looking out for, yes. We're trying to get a little sort of pamphlet out for health care workers in the remote areas to sort of alert them to it so they can find it, look for it.
And measurements for that? It sounds like fasting insulins again.
Fasting insulins and glucose, if you see that, yeah.
Thanks. So now we might turn to the other end of the spectrum and talk about small kids. And maybe looking at babies first. I gather there's a fair bit of evidence that babies who are small for gestational age go on to have problems as they get older. What sort of follow-up? How should we be dealing with those kids?
Okay, about 10% of the population will be underweight, and maybe a quarter of them will not make a normal recovery and catch up. If they don't catch up gracefully in the first year, then they are at increased risk of metabolic syndrome and long-term growth problems. I think it's normal assessment of growth and healthy eating, and trying to prevent them getting that adiposity rebound after the first year of life when they might. So it's really focusing on healthy eating at that point in time.
And those sort of healthy eating messages at that age, you mentioned solids before, but and breastfeeding, is there anything else, or is that the...
Well, we recommend that unless children are overweight, and these ones aren't, they should have normal fat milk.
Mm-hmm.
They should have a healthy, balanced diet, so no exclusions, but not more than about a third of your calories from fat. So you're having complex carbohydrates for about 50-55%, preferably about 20% fat and 25% protein foods.
Good, okay, thank you. We also, I mean, it sounds like from what you're saying that the growth charts are perhaps more important than we perhaps are routinely using in practice. Is that a fair... Would that be a message that,
Well,
that really the growth charts are key to this?
I think growth charts are a tool more than they are a record. I think we tend to think of them as a record of what's happened, but really they're a tool to aid in diagnosis and to record how we've gone in treatment.
Mm.
So,
And the patterns, I guess. But
the patterns,
come to that perhaps. But I guess a common problem for a GP is a child who's below the percentiles for their age, and the parents are concerned about the poor growth. Can you talk us through an approach to that, perhaps in the slightly older child?
Sure. I've always returned to an old study from the Mayo Clinic, which looked at quite a large group of younger children who weren't growing well. And what they did was went back and ascertained how diagnosis was established. And basically, 2/3 of them it was diagnosed from history, 1/3 from physical examination, and less than 1% from doing tests.
Wow.
So it's a classic paediatric history, starting with the pregnancy, the birth, the feeding history, current dietary history, organ function, as well as family history. So it's history, confirmation from physical examination, and then maybe some targeted investigations looking at things which typically you'll get a clue from your history, with some exceptions. You know, celiac disease we now recognise is so common in Western populations that a number of young people will not have symptoms suggestive of it. So I think anyone who is not growing well should have a screen for celiac disease. Apart from that, and Tim might have a slightly different view, but I think most things should be guided by history or physical examination.
Would you agree, Tim?
Yep, you're looking for the genetic causes. You're looking for chronic disease, malabsorption, and you're really trying to sort out the short stature caused by disease from the genetic, familial, constitutional delay, the normal variants of growth. And 95% will be normal variants of growth, and the rest will be. As a rule of thumb, we would investigate, or we would expect to be referred children who are under the first percentile, and children who are growing slowly over a good 12-month period. So it's a growth chart again, and over a 12-month period, a good height velocity. And most growth charts will have a height velocity section on it, so you can calculate how fast they're growing. If they're growing below the 25th centile for their age, then that's a slow growth, and we would investigate those children.
Okay, so that the referral indications, which I suppose is what
under the first percentile,
is under 1%, under the first percentile of height and weight.
Yep.
And under the 25th for.
Or if you've watched them for over a year and they're growing slowly.
Slowly.
So you can be on the 5th percentile and growing slowly and have something serious that needs to be dealt with. But if you've watched them over 12 months and on the 3rd percentile and they're growing along that percentile, then they don't need investigation. It's likely to be familial.
I guess that's always the issue with parental concern too, isn't there? Which is sometimes difficult to resolve.
I think oftentimes you can resolve it with a careful history and demonstration of the child's well-being and plotting of the growth chart, but you can't always.
No.
Yeah.
And referral options in this setting, I mean, obviously your clinic's highly specialised. Is that where people should be referring, or do you think it's to local paediatricians first?
I think the paediatrician first, yeah.
Yeah. Okay, and then onwards.
Yep.
You did mention celiac disease and malabsorption. Can you perhaps talk us through a little bit about the gastrointestinal causes of poor weight gain?
Well, if we go, taken overall, the most important cause is inadequate food, just not enough calories. And that may be a baby problem with behavioural issues, it might be a parental knowledge problem, it might be adverse social circumstances, but by far and away the commonest cause of children being underweight with bowel problems is actually inadequate food. And then we've got celiac disease with the, it's probably 1 in 100 in Caucasian populations now, so it's really quite common. And then the next commonest cause is cystic fibrosis, which is about 1 in 2,500 children. So it's much less frequent. But after that, everything is really quite rare.
Okay. There's been a bit of confusion, at least in my mind, about the diagnosis of celiac and how good the serology is, and how many of those normal serologies will end up having abnormal biopsies. Is that an issue, or is the serology pretty good?
Depends on the circumstances. Research studies show that maybe 97, 99% sensitive and specific. In practice in this state, unless you've got a high titer, and it varies a little bit on the laboratory, but a low titer, in our experience, is not very predictive of celiac disease. So if you just pick it up and there's no other symptoms, I would be reluctant to do a biopsy. If there's a medium titer, no family history, I think they definitely need a biopsy. An isolated high titer, they should still have a biopsy because some of them will have a normal mucosa. What we don't know is whether they're going to go on and develop celiac disease, or this is a marker of autoimmune reactivity. You can do HLA typing, which is thought to be quite specific, but it's reasonably expensive.
Okay.
And fairly moderately specialised.
You mentioned the growth chart patterns, and I think we've actually got some patterns to look at that might be useful to sort of contrast some of the different scenarios. Okay,
and this pattern, which is on the screen now, shows fall off in weight from normal centiles around the first year of life, crossing centiles and falling outside the range, and then slower fall off in linear growth. This, to my mind, is a classic picture of nutritional deficiency. It could be inadequate food, it could be a diseased organ, but it's really not enough nutrition getting to the tissues. And if we can look at the next one, this one shows fall off in length, first of all, in the top part of the graph there, with some secondary fall off in weight subsequently. And this is a problem with linear growth. Most likely an endocrine problem, which you're going to refer to Tim, but it could be a bony problem as well with dyschondroplasia. And if we just look at the last one, this is a child over a longer period, and you can see both weight and height are outside the normal range, below the third centile, but roughly following the normal pattern. And this child has a constitutional problem. It might be small parents. It could be fetal alcohol syndrome, but this might just be a normal child. Do you want to comment on that, Tim?
Yeah, that's the height velocity there would be normal. So, unless there's a great disparity between that height and the parent's height, you'd call it familial.
Okay, well that's useful. As I said, I think earlier, it really reinforces to me the need that I should keep my growth charts in better shape. Yeah.
And as for short parents being just 5'7", I've got a son of 6'2". I don't know what that says, but our final segment tonight takes us to the other end of the spectrum for a look at falls prevention. In September, the Stay on Your Feet program is running a week of activities designed to get older people engaged in physical activity and falls prevention strategies. Many of the activities will be held in rural centres, providing the opportunity for you to link your patients with services in your region. We spoke with the chair of Falls Prevention Health Network geriatrician Dr. Hannah Seymour from Royal Perth Hospital and Suzanne Ralston from the Injury Control Council of Western Australia about strategies for reducing the frequency and the impact of falls.
Falls are the most common reason for older people to present to emergency departments. They consume a total of about 1.5% of the total health resource in WA, so it's about, the costs are estimated to be over $80 million a year at the moment, and they're going to increase exponentially as the population ages.
Falls are one of the most serious issues facing people over the age of 65 in WA. It's the biggest cause of injury and injury-related death in WA for people in that age group.
A fall reduces people's independence. It can lead to significant injury, which can reduce people's level of function. You can also get associated fear of falling, which also reduces people's independence in a different way by them being scared of falling again in the future. And that can exponentially reduce people's function over time. Estimate of the costs across the whole of Australia are $1 billion if you include all of those associated costs. So yes, it is a huge problem, and I think with the ageing population in Western Australia, it's going to become more and more common and bigger problem in our hospitals and in the community. A lot of what you do as a GP is preventing people falling, so trying to prevent people getting unwell for whatever reason is preventing people's falling, because as you develop more medical conditions. So that's number one thing, just doing what you're doing is probably preventing falls. If people have had a fall, I think the first thing to tell them is that we can do things to prevent further falls. They worry, and if you interview people, a lot of the worry is about, I'm going to get put in a home, my family won't want me to stay at home. And again, I think that's particularly important in rural areas where people, to move into residential care, you might have to move a long way away from your family. So I think there's an increased stigma about that in rural areas. A lot of older people won't come and see anybody after a fall. They'll just pick themselves up, dust themselves off and think, I'm all right. And I think that's particularly true of a proportion of rural people who, won't go and see GPs regularly, will only go and see when they've got another problem and might not mention that they've had a fall. So I think that's the first thing, is that we say that one of our recommendations is that GPs should ask older people about a fall at least once a year. The number of medications that you take is associated with your increased risk of falling. Antipsychotic medication, antidepressive medication, and particularly medications for sleep. So, for instance, benzodiazepines, and that would be my one drug that I think we should definitely be reducing the amount of use in the community. And my plea would actually be to stop prescribing them. There's a very good study in New Zealand that showed that by reducing, if you could stop people taking their benzodiazepines, they reduced their risk of falling hugely by more than a half. But at the end of the study, within a month, half the people who'd stopped taking them were back on them again. So I think they're a hugely addictive drug. Their effect on improving sleep is actually minimal, and yet they have very important side effects that aren't really well recognised in the community. A second thing to think about would be symptoms of medical causes of falls, which I think most GPs would be aware of, but flags that there's a reason for the falls that isn't just because someone slipped or tripped. So did they have a blackout? Did they have dizziness as a sign of postural hypotension possibly before the fall? Did they have a blackout? A blackout's particularly a sign of arrhythmias, so did they have a complete heart block, or is their medication slowing their heart and that's why they had a fall? So those are really important flags. Occasionally TIAs or strokes can cause falls. We would recommend in everybody who has a fall that they should at the very least have their calcium and their vitamin D checked, and they should be started on calcium and vitamin D. Now, vitamin D not only improves your bone strength, but there's also evidence to say that it reduces your risk of falls. If people have had a fracture, then they should be started on osteoporosis medication. And most people would usually start with the bisphosphonate first, although there's now some evidence for strontium. I think the really important thing to emphasise to GPs, and that I see sometimes, is I see people on osteoporosis medication, so on the expensive bit, the bisphosphonate or the strontium, but without being on the calcium and vitamin D. And I think it's really important for me to emphasise to geriatrician that all of these trials, every single trial that looked at those medication, all patients were on calcium, and all patients were either given vitamin D automatically or were screened for vitamin D deficiency and vitamin D deficiency replaced. That group of people who don't have a medical cause, who you haven't been able to do, there are still lots of things that have been shown to reduce falls in that population. I guess the key one would be about, again, maintaining a healthy lifestyle, so maintaining good nutrition, and again, maintaining activity and exercise. And there are actually very good studies on very simple exercise programs One in particular would be the Otago exercise program, which has been studied in a number of settings throughout New Zealand, mainly as the study area. And that's a very simple exercise program which is delivered in the home, which encourages people to do simple things to improve their strength and balance.
For those that are at lower risk in the community that aren't having regular falls, then Tai Chi is one of the best evidence-based activities we can recommend for people to do. For those that are at higher risk, they're more supported in-depth activities and programs that are set up that are either done in group, but for those in really high risk groups need to be done one-on-one initially to help build their balance and strength to prevent falls.
If you imagine the sort of exercise involved in Tai Chi, those are the sort of things that we should be encouraging people to do to try and improve their balance as they age. And I guess that's where we at the Falls Network think there's a bit of a lack in what's provided in the community. So there's lots of exercise classes provided. I guess what we need to make sure from a health network point of view is that we know what classes are out there that specifically do help prevent falls and encourage classes to include the balance elements that they might not traditionally provide that will help prevent falls. And so there's lots of places that have falls prevention that have exercise classes available. So local health centres, there's local gyms are obviously a good place to send people, and there are things like the Living Longer, Living Stronger programme, which use the downtimes in gyms so that it gives people a low-cost way of using those facilities to try and encourage exercise. And also there is the Stay on Your Feet programme. So that's a programme that's been delivered by the Injury Control Council of WA, which was primarily aimed at reducing that time to first fall. So health promotion in younger, older people, if you like.
We provide evidence-based information and advice and referral to services to those people to help reduce their risk of having a fall. So we promote the 9 steps to stay on your feet, and through those we try and link people to services and to actually address the issues that they've identified with their health professional, including people like yourselves, to actually reduce their risk of having a fall.
The 9 steps to stay on your feet are published for consumers, but I think they do have a relevance at a more intense level for doctors. And I think if you went through those as a doctor, you could have quite a significant influence on how people interpret those and which bits they take away. Particularly there's one about manage your medications and manage your health, which consumers would come to doctors about, I think GPs particularly, and talk about how can I change these things to reduce my risk of falls.
We've also got a checklist that seniors can actually take into their GP, take into you, which are available through the Stay on Your Feet website to actually tick off their risk factors. So it asks questions about medication, physical activity and those kind of things, and it would be a good idea as well if you could have copies of it and use those with the patients that you think it would be appropriate to do with, so you can identify those risk factors. The Injury Control Council is also in the process of establishing the statewide Stay on Your Feet Falls and Resource Information Centre, and through that patients and you will be able to give us a call and we can provide specific information at a local level about services, resources and programs that are available for people that are appropriate to them. And we can work in conjunction with you to work out for those people what is the most appropriate. So if you deem that they need physical activity or assistance with nutrition or podiatry, those kind of things, we can actually link you and the patient up with those available services in their area. You can call the Injury Control Council office on 9420 7212. The databases that we're setting up, we're in the process of doing that, and that will be an ongoing thing depending on what area people call us from, but it's something that people can actually call us right now and we can provide that information. Well, we're about to hold Stay on Your Feet Week, which is a week with events and activities happening all over the state. It's from the 14th to the 20th of September, and a really large number of events and activities will be held in rural centres. Things like cooking demonstrations by nutritionists, Tai Chi classes, podiatrists providing information sessions about foot care and footwear, and then assisting people to look after their feet and checking their shoes to make sure they're safe. But the vast majority of events are actually around physical activity. So They're providing information sessions, but also physical activity classes by physiotherapists and trained fitness professionals, including the Tai Chi, but also football classes, walking, including some strength and balance, those sorts of things throughout the week. The information around those activities will be on the Stay on Your Feet website. And if you want to get information about those activities, or you think that some of your patients might want information about them, they can call the same number that I gave before for the Resource and Information Centre, which is 9420 7212.
Part of the problem for GPs is that there are lots of trials that have shown lots of different things work, and I don't always think it's very easy to pick out which are the things that apply to each patient individually. If you go out and do an individual assessment in someone who's had a fall and suggest that they change their medications, they take away a few mats, they maybe change their glasses, and they do exercise, the risk is that the exercise, which might be probably the most potent, is harder to do. But what people will say is, oh, well, I've stopped one of my medication, I'm now taking a new medication to protect my bones, and I'll take away those mats, and therefore I won't do the exercise. And certainly there's recently been some studies saying that maybe if we overwhelm people with too many different recommendations, they pick which one suits them the best and don't do the one which would actually be of the most benefit.
If you could recommend for an older person to do one thing to help reduce their risk of having a fall, physical activity, including or in particular strength and balance training, would be it. It's been shown to reduce falls in randomised controlled trials by up to 30%. So if you were going to promote one thing, physical activity would be it.
And I think that can be quite daunting for older people. They're not used to exercising, they haven't been formally exercising, but by doing it in a group setting or in an individual prescribed setting and just encouraging people to be active, that will reduce falls.
And our thanks to Dr. Hannah Seymour and Suzanne Ralston. And once again, all information about Stay on Your Feet and the week of activities can be found on their website at www.stayonyourfeet.com.au. And the site also provides the patient checklists and other materials that might be of use to you. Well, that's all we have time for tonight. Any final thoughts from our panel? David, you wanted to mention falls prevention for kids?
Yeah, I think Hannah's emphasised the elderly, but this is also an issue for children and a great opportunity for GPs to undertake primary prevention through education, making households safer for young children. And if in your country hospitals, other hospitals, careful supervision of children on beds, falls in hospital among kids are a major issue too.
Your word of wisdom, Tim?
Both obesity and short stature is best screened for and managed in the community, and the growth charts is the best place to start to monitor children's growth.
Terrific. Now, don't forget, if there's any part of this program that you'd like to review at a later time, a delayed transmission of the Rural Doctors program will be available via internet web streaming next week. That service is accessible through the Rural Health West website at www.ruralhealthwest.com.au. And please note that the internet transmissions are password protected, so if you haven't already, you'll need to register by contacting Rural Health West. It's also worth noting that the broadcasts are now also available for download from the Rural Health West website as either video or audio only podcast, so you can download the programs and then listen to them or watch them at your leisure. Instructions for downloading the podcasts are available. Just call Rural Health West on 08 6389 4500. We're back again on the 2nd of September with a program for you focusing on cosmetic and plastic surgery. We look forward to your company then. Thanks again to our studio panel, Dr. Peter Maguire, Dr. Tim Jones, and Associate Professor David Forbes. Thanks, guys. Mm-hmm. And thank you for joining us. Good night to you.